this morning in Florida time. Really appreciate you taking the time and joining us for our series and webinars. Today, if you've missed, those people have missed a few, today is number 5 in the series, and we've been a continued program since the pretty much lockdown pandemic has struck the world. Again, appreciate you being here. Today is not just another webinar with a great clinician, but it's one day closer till we can get back to some kind of normality. There's states in the US that's been opened, and businesses for business of how can I say, non-emergency elective procedures are starting to slowly creep our way, which is very exciting. I'm sure you guys are chomping at the bit to get back into what you love doing. Besides this continual education that we've been put on, I'm sure you've honed in on some of the skills. Skills I've been pretty much honing in on hobbies is perfecting cocktail shaking, trying to do a bit of exercise, trying to do some reading. And I must say, I feel better for the reading part, not the cocktail drinking, mixing side of things. But I'm sure you're getting back to some of the things you used to do and were very good at as well. I would love to introduce Dr. Safa Tahmasebi. Safa Tahmasebi is a long friend of Southern Implants. He challenges us. He phones us to perfect things. He is a perfectionist himself. He's always seeing how he can do things better, and as I mentioned, challenging us how we can do things better. We love this. We love doing this. It's in our DNA, Southern Implants DNA, and we do appreciate that. Dr. Safa Tahmasebi received a Bachelor of Science in Biology degree from St. John's University at Queens, New York in 2005, and his Doctor of Dental Surgery degree from the State University of New York at Buffalo School of Dental Medicine in 2009. He went on to complete his advanced education program with a Master of Science in Prosthodontics at the West Virginia University School of Dentistry in 2013. Dr. Tahmasebi, in 2013, he joined the same-day Dental Implant Brandmark Osseointegration Center in Dubai as a clinical director and specializing in prosthodontics side of the procedures. In 2019, Dr. Tahmasebi moved back to the United States to join the Metro Charlotte Clear Choice Dental Implant Center as a key member of the team specializing in immediate loading protocols and full mouth implant rehabilitation. He's been lecturing on the full mouth implant rehabilitation protocols, both nationally and internationally at major conferences around the world. Dr. Tahmasebi has embraced these special implants of Southern Implants, these site-specific implants for the benefit of his patient, and has tweaked his protocols and concepts accordingly. I'm very much looking forward to the presentation this morning, Dr. Tahmasebi. And without further ado, I'm going to hand it over to you.
Thank you so much, David, for such kind words and such a great introduction. I'm very happy to be here as we go through this difficult times in quarantine. So yes, thank you again. And I heard you say this a couple of days ago. Shout out to the frontliners, healthcare providers, people that are risking their lives trying to protect the rest of the public. So so thank you for all of those people. So without any further ado, I'm just going to jump right into this presentation. I wrote this presentation. It's a new presentation, fresh out of the oven. David, can you hear me? I lost your picture there. Can you hear me well? Just making sure that you guys hear me well.
Dr. Tahmasebi, yes, we hear you perfectly well.
Okay, so I wrote, this is fresh out of the oven. It's a new presentation that I wrote, and basically the theme of the presentation to the monolithic full arch zirconia prosthesis. So with everything that we do in life, we must have goals and responsibilities. And in my opinion, the track to full arch reconstruction has two goals or two responsibilities. One of them is the surgical, and the other one is prosthodontic. Our surgical goals is a no grafting, minimal invasive surgery protocol, using native bone, immediately loading almost every case, avoiding multiple procedures, placing as many implants as needed for that particular case, definitely using the tilted concept, and making sure that our bridge is a screw retained prosthesis. You know, this is perfectly in line with what Brennemark taught us 30, 40 years ago, when he said that, you know, we should avoid unnecessary and advanced complicated grafting procedures. You know, I see a lot of unnecessary stuff being done on Instagram dentistry. Let's not forget that attached to these cases are patients. These patients have their lives. They are busy. They are afraid of us. And you know, they want to, at the end of the day, all they care about is teeth. They don't care what implants you use, what system you use. They just want to spend the least amount of time in your office. They want to come in, get in, and get out. So it's very important to give the patients what they want. Our prosthodontic aspirations are, my friend Stuart Letton calls it over-engineered to last and built to last. A zirconia prosthesis, in my opinion, that has 12 teeth, it's completely hygienic, but more importantly, it's a worry-free functional prosthesis. By that I mean a prosthesis that almost has very little to no maintenance at all. The alternative to this profile prosthesis is the tooth-only prosthesis. David, I could begin myself again. Yeah, thank you so much. So the two, and I'm not saying that, you know, this prosthesis is not the right prosthesis, but what I am saying is I have seen so many problems arise prosthetically with the tooth-only prosthesis that I think the right prosthesis is the profile prosthesis. Now, I wasn't thinking like this before, but I certainly think like that now. And we'll talk. This famous saying of starting with the end in mind. If you were going to build a house, first you'd have to decide what kind of a house or home you're looking at. Are you looking at a condominium? Are you looking at a villa? Are you looking at a two-story building? Are you looking at a townhome? Whatever it may be, you must first decide what type of the residential property that you'd like to build. Once you do that, and the next thing you need to do is you need to decide what type of a, once you find out the type, then you need to find out, then you need to decide on the material that you're going to use for that particular prosthesis. Is it going to be made out of concrete? Is it going to be made out of wood? What type of a building material are you going to use? Once you get all those decisions made, then you can put that into the construction. So that same thing applies to the full arch implant reconstruction. Carl Misch very famously said that the primary factor that determines this restoration type is the amount of inter-arch space, and we'll dig a little bit into that. When we don't have goals, aspirations, responsibilities, and when we don't think ahead, we don't plan these type of cases, these are the situations we end up in. I mean, this prosthesis is certainly not indicated for this particular patient, or maybe this prosthesis was not indicated properly. So it's very important to understand the prosthesis that you're going to use for that particular patient. Each one of these prostheses has their own dimensions, their own requirements. We must first understand the type of prosthesis we're going to use and the material, and then execute it properly. Because ultimately, what ends up happening is aesthetic failures. If you look at this case, for example, where do we go from here? Do we have to start over again? This patient has 6 implants. Many things has gone wrong here. And as you can tell, there was no planning here. So there was no thinking ahead. Or prosthetically, at a more in-depth detail level, looking at voids like that inside of the prosthesis, and over-contoured zirconia around the thigh base here. These pictures I took exactly once I received the cases from the laboratory. I turned them around and I took these pictures. Look at the cement all around that thigh base on the right side picture. We have to know the material, we have to understand what it can do to our patients, and then we have to make adjustments necessary. We have to have a better conversation with our laboratory to avoid such problems. So for me, the material of choice is the monolithic zirconia, because this material has been around for roughly about 15 to 20 years. And it was only until recently, the past 2-3 years, where this material became very commercially available. It has very little to no wear, and then its space requirements are a lot less than some of the other materials out there. I'm talking about the hybrid. And it has much lower maintenance because of its low wear. And obviously we know it's biocompatible, we know it's very strong, and obviously if you do the right things, it's completely aesthetic. So one of the problems that has happened with this prosthesis is the dimensions and the design of this prosthesis has been sort of confused a little bit among many clinicians. We are designing and treating this prosthesis, the monolithic zirconia, as a PFM, or we are confusing its space requirements with a hybrid. And so it's causing a lot of issues that I hope that I could go over today. As far as the literature is concerned, there's not really a cutthroat long-term literature that says if monolithic zirconia is the material to use. But here's a study by Dr. Bidra, where they looked at the survival of 2,039 full arches, a retrospective study, and they reported a 99% success rate after 5 years. So, you know, the literature is on its way. I think the monolithic zirconia, it's proving to do very well. And, you know, a lot of people are aware of this now. Commercial laboratories in the United States are offering 5 to 7 year warranty on the fully monolithic zirconia. And that has really changed the way I personally practice, because I offer that same warranty to my patients. And it gives the patients a peace of mind that when they are buying a treatment from you, they know that they will be taken care of. So this brings me to the famous quote by Harry Truman, that the only new thing in this world is the history that we don't know. One of the biggest problems that a lot of people are doing right now is that they are not looking back in history. So for me, to understand the monolithic zirconia, we must first look at some of the other prostheses that were in the market in the past. The metal acrylic prosthesis, the hybrid, which was first a gold framework and then a titanium framework, had a lot of problems. Obviously, it did very well, but it required a lot of space. And we saw all the problems that came with this prosthesis because of the amount of space that it needed. Also, it was wearing a lot, and so teeth were popping. The color of the prosthesis was changing with time. It was very porous. So the repair time, we spent 2 to 3 hours every morning repairing old hybrid cases. And then the metal ceramic, the PFM, phenomenal prosthesis, doesn't require a lot of implants. It doesn't require a whole lot of interocclusal space, but it's very expensive and it takes a lot of lab hours. And when it fails, the failures are catastrophic. Porcelain fractures are very difficult to repair. The metal cools and heats at different parts. A lot of clinicians right now are using base metals. These metals don't behave as good as precious metals, and bubbles and porcelain chipping and corrosion around the implants is something that has stopped me from using this material entirely, although it is seldom required in cases where we don't have any interocclusal space. And then the monolithic zirconia, this is my go-to. It has the shortest track record, but it is not as expensive. Right now, this prosthesis is becoming very, very, very affordable, to the point that we are actually offering an upgrade to our patients. We are taking old hybrids and we are converting them to zirconia for a moderate fee. It does, and the space requirements is less than hybrid, but it's more than a PFM. And we'll talk a little bit about this prosthesis for the remainder of this lecture. So again, the metal ceramic required anything between 70 to 19, sorry, the metal acrylic required anything between 17 to 19 millimeters of space, and he had a lot of issues. And then the metal ceramic also had problems. The PFM is not a worry-free prosthesis. It's not a prosthesis that you could put in the patient's mouth and say, okay, I never have to see this patient again. You will have problems with that patient at some point. So the outline of this denture is to go over some of these attributes of monolithic zirconia. And once we do that, then we look at the criteria to make this monolithic zirconia the way it should be, because there's a lot of confusions and modifications that I'm seeing today. Everything diagnostic evaluation that leads into a surgical protocol that implements and gives you the monolithic zirconia. So the diagnosis and data collection is how I start every case. And I feel like this is the step that is being overlooked. We are too busy and we rush sometimes and we miss some very key important points. So the way I start these type of diagnoses and data collection criteria, and it leads me to the prosthesis type and the prosthesis material. The first two criteria that I look at is the incisal edge position and the vertical dimension of occlusion. If you have a partially edentulous patient where there are some remnants of some older teeth, whether the teeth are in the right place or they're in the wrong place, there's always one tooth that gives you a lot of clues. And you can use that tooth to put the incisal edge in the right place. If you're dealing with an edentulous patient, then you go to the wax rim. The good old wax rim, it gives you the midline, it gives you the smile line, it gives you the length of the teeth, it gives you the canine positions and the occlusal plane. The tooth that display, the way we get to the incisal edge position is we look at the tooth display at rest. This is obviously affected by lip mobility, by patient's gender, by patient's occlusion, by patient's age and phonetics. But one thing that I would say is that what my experience has been is that older patients show a lot less maxillary teeth and a lot more mandibular teeth. Just watch politicians on CNN. Every time they speak, they show a lot of lower teeth. This is very important because if you have a patient at the age of 50 and they come to you and they want to tell you, doc, I want to have more of my bottom teeth showing. You need to know this fact that was written in Dr. Vick's paper in 1978, that patients show more lower teeth. So you need to advise patients that if I do that for you, when you turn 70 or 80, you're not going to show any maxillary teeth and you're only going to be showing bottom teeth. So Vick showed us that at the age of 30, the incisal tooth display at rest, that is when the patient is resting and the lip is all covering the teeth, you're looking at anything between 3 to 3.5 millimeters of tooth display. At the age of 50 is 1 to 2 millimeters. And as the patient gets older, at the age of 70, only 0.5 millimeters. This is very important information because it allows you to put the incisal edge at the right place. The next thing we need to look at is the lip mobility. This is a young patient and you can see the corners of the lips are rising out significantly high. If you were to do a full mouth rehabilitation on this patient, then the bone reduction will essentially remove the patient's premaxilla. It is very important maybe for some of these younger patients to delay full mouth rehabilitation and to give them fixed prosthodontic tooth rehabs before we take them into full arch reconstruction. So the way we continue once we find our incisal edge position is that we find the residual ridge that is left, and then we put these patients inside of a denture, a trial denture, the good old denture that we removed, that we learned from removable prosthodontics. Once we subtract that denture, then we can know where the occlusal plane is. Once we know the occlusal plane from the incisal edge position, then we pretty much have an idea about the interarch space, and that can help us choose the prosthesis type that we're looking at. Again, these diagnoses and data collection is very important before proceeding. In this case, for example, a typical central is about 11 millimeters. If you have 5 millimeters of space, then we can do a full arch zirconia here. But if the incisal edge was a little bit higher, then this case may not be able to be done with zirconia, and we need to implement some type of a different material or go into bone reduction. And so this is very easily done. Patient comes in, the incisal edge is, for example, in this case, is in the right place. We use some bite record material and a record base. We take a quick impression. We mount this on a very regular hinge articulator. Now we have an idea about the incisal edge position and then the intra-arch space. And clearly you can see in this space, in this case, that the space is very limited and bone reduction is absolutely mandatory in this case. We can't do it any other way. Videography is also very important because by having videography, we can also make very important decisions. Just by an iPhone, having the patient speak, again, in this case, the incisal edge position seems to be in the right place, but there's not enough interocclusal space, and we need to either open up the space or to do significant amount of bone reduction. And the way we mount these cases is very simple. We find the incisal edge position at rest, and then using the appropriate overbite and overjet, we mount this on a hinge articulator and we move forward. Today, we do this digitally. We scan the models in our office using a 3-shape scanner, and you can see the positioning. The red is where the teeth used to be, and the position in the black is where we digitally have lengthened the incisal edge position, and we have moved the bottom teeth forward a little bit. We superimpose that. The digital designers finish that for us, and they convert that into a digital denture that is printed or milled and is returned to us to be used as a surgical guide. The next thing I look at is the smile evaluation. It is incredibly important to look at the smile before starting a full arch rehab, because one of the things that's very important is that we may miss many vital information by not taking pictures. It boggles my mind how people start these type of cases without taking fantastic photos. Ruben in '74 described 3 types of smiles: a commercial smile, a social smile, or a spontaneous smile. A lot of these patients that come into our office for these full mouth rehabs are very shy and fearful patients. They will not give you the most spontaneous smile. They're very shy. You almost have to be a comedian. You almost have to make them laugh and giggle. And that's very important to make them feel comfortable, to give you that very large smile, because once you see that, then that will stop you from getting into trouble at the end. Tijan in '84 described 3 types of smiles. There are patients that have a high smile. These are patients that show majority of the teeth, and they show a continuous band of gums as the picture on the left. These are about 11% of the cases. And then we have a medium smile. These are patients that show probably pretty much the entirety of the teeth, and they show in a proximal papilla, but they don't show the gingival gum line. And then you have patients that have a low smile line. These are about 20% of the cases, and they have no gingival display at all. This is very important to figure out, because the 11% of cases, these are the cases that need extra TLC. In America, TLC is tender loving care. These are cases that you need to really sit down and put your brains together, and so you can come with a better treatment plan. For example, these 2 patients are going to be treated completely different. The picture on the left is a patient with a hypermobile lip with a lot of maxillary excess. The patient on the right does not show a lot of gingival display. So when we look at an interocclusal, he already has had the resorption that we need. All we need to do is do a little bit of bone reduction and give him a full arch reconstruction. So the lips at rest is very important to look at, because when we look at the smile, if the lip covers the gingival line, the gum line, then we're okay. But as soon as that lip starts to rise higher, and then now the gingival line becomes visible, then these are the cases that we need to think about doing bone reduction and gum reduction, or doing them with a tooth-only prosthesis, but those are very difficult to do. So if we have a case where the gum line is visible and the smile line is above the gum line and the continuous band of gingiva is visible, then what we can do is what we have been doing for a very long time. Place an implant according to the criteria. We can do a partial extraction therapy. We can do the dual zone technique that was described very well by my friend Dr. Chu and Dennis Tarnow. And we can try to preserve and reduce the amount of bone loss and gum loss with time, but that is very difficult to do. I think the only way you can do it is with partial extraction therapy, and we'll talk a little bit about that in the future. But what you can do is, the literature tells us that if you want to reduce or hide that gum line, you need to do alveolectomy or bone reduction, 2 to 3 millimeters past that smile line. And once we do that, then we are looking at a profile prosthesis. Now, this is a prosthesis where it's composed of white and pink. A profile prosthesis is my preferred prosthesis now. It never used to be, but now it is really the way I like to treat implant cases, because now you can hide that transition line under the lips, and the aesthetic and the long-term prosthetic success of these cases is a lot higher. So the transition line is the line that is formed between the patient's gum and the prosthetic interface at a profile prosthesis. If we don't do that, we're looking at situations like this where the gum line is visible. This is lack of planning. This is lack of taking correct photographs and diagnosing a gummy smile. So what we do today is very minimal bone reduction. Bone reduction is a very sensitive topic to many people. We can use an oscillating saw here. All we have to do is remove a little bit of bone and we are game. And once we remove that bone with an oscillating saw, then we go over it with a handpiece, and we round all the edges. The thing that I'd like to say about bone reduction is that bone reduction is a topic that I have been thinking about for a long time. And I think initially the problem with bone reduction was that it was being done a bit too much. And so one of the things that I would say about bone reduction is, if you don't do it, you will look at cases like this. Every hour there signifies a problem. You can see that this prosthesis is begging for space, a space that it doesn't have. So what it ends up doing to us is that the transition line becomes visible. And also this prosthesis is not going to have a very successful long-term prognosis. But the thing I would say about bone reduction is that sometimes the bone reduction is done too much. And I think the result of that is because of lack of planning, lack of diagnosis and data collection. I think we have to reduce and remove the appropriate amount of bone and not excess. If I haven't learned anything in life, is the yin yang, a balance in life. You don't want to reduce too much bone, and you don't want to reduce a little bit of bone. This is a picture that I got from Instagram. If you look at it, the patient's maxilla is sitting on the tray table. We don't want to be doing that. That's a bit too excessive. But we don't want to not do bone reduction either, right? The person who did this case obviously does not understand the resective and the bone loss things that happen at the time of extractions. Once a tooth is gone, the bundle bone is gone, and the resorption process is an ongoing process that will not stop. Which brings me to one of my other favorite quotes by Albert Einstein. Insanity is the definition of doing the same thing over and over again and expecting different results. Once we understand the concept of why we have to do things, we will not do them. We will not make the mistakes again. So it doesn't matter where the transition line is, as long as it's above the gum line, then that will definitely get us out of a lot of aesthetic failures. The next one is the type of defect that we're looking at. Carl Mesh described this beautifully in his book, that again, the type of prosthesis that you use depends on the amount of intra-arch space that you have. And he classified the prosthesis into 3 different criteria: PF1, PF2, and PF3. PF1, in my opinion, does not really exist in the full arch reconstruction world. This is a prosthesis that is only white. It does not include the papilla. It is literally just a clinical crown. The PF2 is the patient's clinical crown, including a papilla and beyond the CJ. These are long-looking white teeth. And then the PF3, this is the profile prosthesis that we talked about. This is the prosthesis that has the white and the pink. And as I described earlier, that in my opinion, I don't believe that PF1 exists in the full arch reconstruction world. So you have to choose either from a PF2 or a PF3. So it is important, it is a decision that has to be made by the surgeon, what type of a surgeon do you want to be? Do you want to be a PF2 surgeon, or do you want to be a PF3 surgeon? Do you want to be a PF2 prosthodontist, or do you want to be a PF3 prosthodontist? And it's a decision that you have to make. This is a PF2. You notice there's very little papilla. The papilla is blunted, a very long looking white teeth. And so when it comes to the PF3 or the profile prosthesis, it doesn't matter how much pink you have, as long as there's a combination of white and pink, that pretty much, for me, signifies a PF3. The difference is the amount of bone loss. If you have more bone loss, you will have more pink. If you had less bone loss, you would have less pink. And that brings me to the tooth-only defect and the composite defect, very well written and described by Dr. Edmund Bedrosian in 2008, where he categorizes or divides the cases of the full arch into tooth-only defects or composite defects. Tooth-only defect, again, is only the white part, which in my opinion is a PF2 with almost no papilla. And then a composite defect is a combination of white and pink, and the amount of pink depends on the amount of bone loss. And then he also describes radiographic evaluation. He describes the jaw, particularly the maxillary jaw, into 3 different zones. Zone 1, which is the anterior teeth, canine to canine. Zone 2, which is the premolar areas, and zone 3, which is the molar areas. So I personally actually categorize zone 3 as, pterygoid implants at zone 3. So based on the amount of bone that we have, we plan how many implants we place and where we place these implants. But the goal is to have a 12-tooth prosthesis, whether it's a composite defect or a tooth-only defect. So let's look at this tooth-only defect, for instance. When we have a tooth-only defect, we have to place more implants. Because, and again, this is talking about zirconia only. Most of my presentation is about the full arch zirconia, full arch monolithic zirconia. And one thing we have to decide is, do we need more implants for a tooth-only defect for the monolithic zirconias? And the answer is yes. And I'll explain that here in a little bit. But the arrangement should be as such, limiting the amount of freestanding ponics. Sometimes the maxillary sinuses pneumonize and they move forward, and that's when we can tilt implants. But again, we need at least 6 to 8 implants for a tooth-only defect if we're using monolithic zirconia. Once we have more resorption, then a tooth-only defect will not work here, because then these teeth will be significantly big, and in the patient with a gummy smile, this will be an aesthetic failure. They will look like they have horse teeth. So then that's when we plan for a composite defect prosthesis. These type of prostheses have pink and white. Now, 4 implants would work very well on these type of cases because there is more zirconia. And because there's more zirconia, we can make these zirconia prostheses stronger. But if it was a PF2, then I would need more implants. Again, the composite defect can be bigger, right? So this is a patient that has significant amount of bone loss. She still has bone in zone 1 and zone 2. So we put the implants in the first premolar position, and we cantilever the second premolar and the first molar. But the only way we can do that by double cantilever is when we have a very large prosthesis vertically. When we don't have bone in zone 2 and zone 3, and we only have bone in zone 1, then we have to look at the zygomatic option. And it's a great option, either the quad zygoma or the single zygoma. The zygoma implant has proven to do very well. So when we look at a tooth-only defect, we have to plan ahead of time. If you look at the picture on the left, this is the tooth-only defect with a low smile line. It doesn't matter what you do underneath the lips. So it could be scalloped, it could be flat, it could be irregular, it doesn't matter. But the picture on the right, where the patient does have a high lip line and the gum line is showing, then we need to scallop that gums, and we need more implants, like I mentioned earlier, for the PF2. But on the picture on the right needs sculpting of the tissue, the patient on the left not so much. And this brings me to a wonderful paper written by Dr. Fernando Rojas Vizcaya from the University of Chapel Hill in North Carolina, where he describes that if you are going to do a PF2, he says that the implant position should be 14 millimeters apical from the incisal edge. And then once you establish that, then you use that position to place the rest of the implant. And in the picture in the bottom right, he shows where you develop those conic spaces. Very beautifully written paper, but as you can see, the surgical ramifications of this type of surgery is very difficult. And even if you do establish it, sometimes a patient with a gummy smile can be very difficult to control. So beautifully done here, PF2. I don't have any problems with PF2, but the surgical responsibilities and the prosthesis complications, in my opinion, with the PF2 are great significantly, especially because you need more implants. And when you need more implants, the surgery becomes more difficult and the fit becomes very difficult to establish. Now, if we look at a profile prosthesis or a composite prosthesis such as an FP3, then you need less implants because this prosthesis can be bulkier. The tilted implant is significantly welcomed here. This is a flat prosthesis, very easy to get this prosthesis surgically, like I showed earlier with an oscillating saw. We can establish a prosthesis that's cleansable. Now, the patient on the right who needs a profile prosthesis and has a high smile line, like I mentioned again, this is a situation where the transition line can be a problem. That's why we need bone reduction here. And once we do the bone reduction, then a couple of implants, 2 implants, and all on 4 would be perfect here because this prosthesis is very large vertically. So what about the number of implants? What is the right number of implants? We hear this all the time. Most people say an all-on-4, 4 implants is enough. Here, I'm sitting here and telling you need more implants. Yes, you need more implants for a PF2 or a tooth-only defect. And the number of implants has been shown in a significant amount of studies. But the idea is you'll need to have an even distribution of all the implants along the curvature of the occlusal arch. If you have a bench, a park bench, and if you sit on this bench and you push it forward or you push it backward, it will fall. But if you put that same legs of the bench in a tripod, and then you put the top of the stool on top, then you have a rigid prosthesis, you have a rigid stool. So it is not about the number of the implants, it's about the distribution of the implant, and it's about the load carrying capacity of the implants. Scalat, Borangard, and Brunsky wrote this beautifully in 3 different papers talking about very similar results, in that it is not about the number of implants, it's about the position of the implants. And in this study, they compared 6 implants versus 4 implants. And they showed that the highest load carrying capacity was on the first implant and the most terminal implant. And as you can see, implant in the position number 2 and number 5 had very little bit amount of load on them. So from a biomechanical standpoint, from a pressure on the bone standpoint, 4 implants is enough. We don't need 6, but the implant need to be distributed in an appropriate anterior-posterior fashion. But monolithic zirconia is different. You see, monolithic zirconia is a very strong prosthesis. It has a high fracture toughness of 5 to 10 megapascals and a flexural strength in a homogeneous material ranging from 900 to 1400 megapascals. That's also considered a tensile strength. So this material is very strong. However, it has one problem. It has a very high modulus of elasticity of about 205 gigapascals. So what that means is that this material is virtually unbendable. The higher the Young's modulus of elasticity, the less elastic this material is. This material is very stiff. For example, titanium has twice as much elasticity as zirconia, right? And the human bone has 70 times more elasticity than the zirconia. So if you're going to put a patient in a PF2 prosthesis, for example, a tooth-only defect, and the jaw, the human jaw is flexing, and you have this rigid prosthesis that doesn't have any elasticity, then what's going to happen is that you're going to have a fracture right down the center where there is an excess amount of pontic space. So with tooth-only defects, I recommend placing more implants, not because of the need of them from a load carrying capacity, but because of monolithic zirconia, so that we will not have fractures. Even in this situation, one implant is enough, and I'll show a case where this is true. So for a PF2 material prosthesis, we may get away with 4 implants, but you don't know 100% if this is going to be a void-free prosthesis. You don't know if this prosthesis is going to outstand the patient's life. And then this is absolutely contraindicated. Double cantilever on a PF2 tooth-only defect. I've seen people do this. Never must we do something like this. Because even when we do have a profile prosthesis, the distal cantilever, when you have 2 of them fractured, so the length of the cantilever has a significant amount of effect on the failure. So the longer the cantilever, there has been a numerous amount of studies that have shown higher failure rates. So it must be, so what I'm saying, must we forget about the PF2 prosthesis, the tooth-only defect? No, I'm not saying that. But what I'm saying is that you need to do a perfect surgery, especially if the patient has a high gum line. You need to scallop that tissue, and you need to place more implants. And so if you are going to do a PF2 prosthesis, then the cross-section of the connectors should be 9 millimeters square. The cantilevers, if you are going to do cantilever, there should be no cantilevers, but if you are going to do cantilever because of the sinus, then I recommend 12 millimeters square, and limiting the prosthesis to only 1 pontic. If you look at this image on the bottom, there's tooth implant, tooth implant, tooth implant, tooth implant. So pontic implant, pontic implant, pontic implant sequence. So would you do a zirconia prosthesis on this type of a case? No, because if you look at the upper left, there is a 3 pontic space. Once this patient bites very hard and the prosthesis flexes, especially if you're looking at a Broxer, this prosthesis will fracture. And so it's very important to have a conversation with the laboratory technician in making PF2 prosthesis to make the connector sizes thicker. We must communicate this with our laboratory technicians. I personally tell my technicians to send me screenshots of the connectors before milling. It's important to have this conversation with them, because when we don't do that, we have complications as such. But the composite defect, you don't have that worry in your head. See, with the composite defect, you have a profile prosthesis. The zirconia is a lot thicker. So because in bulk, it withstands the flexure of the jaw. And if we don't have a lot of bone, then we can place less implants with the profile prosthesis. So when you look at a case like this, where this patient has a tooth-only defect on the mandible and a composite defect on the maxilla, the smile line does not show the transition line. We look at videos before starting of the case, and we notice that this patient obviously has a lot of problems. Every time she bites down, the partial denture is moving up and down. We look at the radiographic evaluation, and we see that she has bone in zone 3 and zone 1 and maybe zone 2, but this is where you need site-specific implants. And this is where the max implant and the angled implant, the coaxial implant, comes into play. Because we need a 12-tooth prosthesis. And on the bottom, in this case, we did a PF2 tooth-only defect. Today, I would have done that differently. As you can see, the top is a PFM. Today, I would have made this out of monolithic zirconia, but I would really thicken the prosthesis. I would really thicken the connectors. And then the bottom, I will place 6 implants if we were not going to do any bone reduction, but I would definitely do bone reduction here and make a profile prosthesis on 4 implants. This is how the prosthesis went. This is a 4-year follow-up. As you can see, the top is a composite defect. The bottom is a tooth-only defect. But again, today I would do this case a little bit differently. And this is the smile. And the patient was extremely happy. So that brings me to the monolithic zirconia. The monolithic zirconia for a profile prosthesis also has to have certain dimensions. For example, it has to have 14 millimeters from the crest of, not from the crest of the bone, from the multi-unit abutment to the anterior incisal edge. We'll talk a little bit more about that. We can have 2 pontic spaces, something we cannot do for a PF2 or a tooth-only defect. but we need to really thicken up the connectors. We try to limit one cantilever maximum, and the posterior height should be anything between 10 to 12. The intaglio, or the underneath of this prosthesis, needs to be flat or convex, and with very little bit of facial porcelain layering, we can make these prostheses look very good. And my friend Stuart Luton in Ireland does beautiful monolithic zirconias, probably the most beautiful I've seen in the world. Some really great work he's doing there, and I can't wait to travel to Ireland and to hang out with him. So once we have done our data collection and diagnoses, then we can implement a surgical protocol that can give us the right prosthesis type. Once we know the prosthesis type, then we choose the prosthesis material. So what are some of the dimensions and the design problems we see for zirconia? For example, this I got from my friend Alfonso Pinheiro in Seattle. He shows that at the implant placement, the picture on the right, you have that excess tissue, but after 4 months, you have that tissue die back, right? So the height of the multi-unit is very important. This is something we don't pay attention to. Does this mean we need to put on implants deeper? Does this mean we have to use lower profile multi-unit abutments? I think so. Because as in this picture, you can see the requirements for zirconia is 14 millimeters, but from where? From the crest of the bone? Yes, but what people are doing is that they're measuring to the crest of the bone, 14 millimeters, and then they put a multi-unit on. But then you lost 2 millimeters of space for the multi-unit right there. So if we are fighting for space, 2 millimeters can change a profile non-ridge lap prosthesis to a ridge lap prosthesis. So 2 millimeters is significant in prosthodontics. So what I recommend is placing the multi-unit abutments deep enough so that your flap is flush with the top of the multi-unit. It's very important to do that. You would say, well, these multi-units are flush with the bone. It looks like it's very deep. Unfortunately, with the full arch reconstruction, you have to do that. And you have to use an implant system that will allow you to seat that multi-unit abutment and has the appropriate bone mills so that if there's any bone interferences, the multi-unit can seat. Now, with the external connection, Southern just recently came out with the platform switch multi-unit. So that has really helped. So there's two scenarios that can happen. You have the subgingival on the left, and you have at gum line. I recommend the subgingival, having that multi-unit deep into the gums, or you can have it at the gum. But what you don't want to do is the picture on the right, the transgingival abutment. That abutment is above the gum. So what technicians do is that they give you a prosthesis, and then they ridge lap it past the tie base finish line. That is a big no-no. That causes a lot of problems in seating the prosthesis, in cleansing, in a long-term prognosis. Here's a picture of how that is. You can see the extra zirconia going over and down. This is the problem. This is because of lack of attention to the height of the multi-unit. This raises the problem in the future because food accumulates there, and then you can never get it out. Here's another picture of it. A right prosthesis is a prosthesis that has a flat to a convex, like you see in this picture, and the multi-unit is a little bit deeper so that you have room to come out. Here's another prosthesis where the multi-units are flat. You can see that your multi-units are in the same line of the zirconia. They're not deeper. So that excess tissue right there does become a problem, because what technicians do is that in order to give you an aesthetic prosthesis, they ridge lap that excess tissue. So it is very important not to do that. As you can see in this picture, they have ridge lapped the zirconia around that excessive tissue. You either have to cauterize that tissue or cut it, or you have to do it early on from the surgery. Here, my technician is taking a burr after surgery is done and sort of molding the soft tissue moulage. All you need is an e-cutter or a lab burr, a football burr, and then you go there and you scallop the tissues. You roughly remove anything between 1 millimeter to 2 millimeters. I can't tell you how much to remove because everybody is different. Every lab technician is different. It depends on your surgeon. It depends on the suture closure. Once that's done, then you take that prosthesis and you make sure that the intaglio is convex and you remove any ridge laps. And what ends up happening is when you do it this way, After a while, after 4 months of healing, when these patients come back, the ridge is perfect. Look how flat this ridge is. It's not very difficult to make a prosthesis on this ridge. It's completely flat. There's no ridge lapping, there's no excess tissue, there's no need for cautery. Because when we make prostheses like this, ridge lap, the tissues look like this. They look wrinkled, irregular, very difficult to go around. And zirconia doesn't work in this type of prosthesis with that amount of excess tissue. Now, there are many different surgical protocols. Dr. Stuart Luton does his own. You just have to have a good conversation with your surgeon and communicate with the surgeon and ask the surgeon, how do you want me to do this? How can we make a flat prosthesis? So one of the things that I think the co-axis implant helps in is look at these two pictures here. The picture on the left is a straight implant with an angled abutment. The picture on the right is a co-axis implant. The picture on the right has subcrestal angular correction. The angle is corrected inside of the bone. But when you compare it to the picture on the left where you need an angulated abutment, that's a couple of millimeters of space. Again, if we're fighting for space in prosthodontics, then we need to use fixtures that are smaller. The co-axis fixture here gives us extra space. And so when we look at a case like this, the co-axis implant allows us to do a PF2 prosthesis. What about the finish of the tie base? We see pictures like this. This is exactly how I received this prosthesis from the lab. Look at all that excess cement around the tie base. Because when you do that, then this is what you end up with. As opposed to having a very clean multi-unit, so that when you remove this prosthesis, say in 4 to 5 years, the tissues look as healthy as when you inserted the prosthesis. One of the problems with that is that the tie base has many disadvantages. For example, it's short. So if you have a long prosthesis, there's tie base decementation. And if you have, which you see here, a tie base decementation. And if you have tilted implants or a little bit of off-center implants, because of the lack of path of draw, what ends up happening is that technicians will take the zirconia and they will gut out the inside and then they would cement it on. That has been solved for me with the passive abutment, because the passive abutment allows you to, stops you from having a path of draw problem. So the screw clamps the prosthesis into the tie base, into the passive abutment. Don't have time to go into the tie base significantly, but it has really changed the way I do monolithic zirconia, because it gives me a fit of 2 microns. And the results is fantastic. Here's a case on 6 implants on the passive abutment. You can see once you superimpose the teeth on the model, and then you subtract the teeth, subtract the passive abutment and the teeth, you can see the passive abutment right there. And in this case, I use gold screws onto the zirconia, and this case has been in function for about 4 years now. And so this is the same case, 6 implants for a profile prosthesis and monolithic zirconia, evenly spaced out with the correct connectors on a passive abutment. And here's the X-ray. And here's the case, same case with gold screws, the GSS3 being placed onto the, the gold screws, multi-unit screws, the small gold screws are inserted. And look how clean that prosthesis, the tissues look, and the prosthesis has a perfect passive fit because of the passive abutment. So we applied the passive abutment to our full arch zirconias, and the results are fantastic, as you can see. We don't have that cement line around and that gutting, as you can see. And what it gives us is the perfect fit. And because we have a perfect fit, we have great bone levels long-term. And I thank Dr. Andrew Ackerman, one of my mentors, friends, a prosthodontist from Johannesburg. He has really changed the way I do implant prosthodontics. This man is an incredible human being. I learned from him so much, and it's such a pleasure to have known him. So let's look at a case before finishing up. This is a case that I failed to do the appropriate diagnostic tools here. This patient was a bruxer. He had a little bit of sleep apnea that I didn't know about, that I didn't inquire about. When we look at the radiographic evaluation, he had bone in zone 1 and zone 2, which is perfect for an all-on-4. So we placed 4 implants and I put him on a PFM. This is some years back when I was doing porcelain fused to metal, and the results were perfect, right? I mean, it looks beautiful, looks great, 12 teeth. It's a profile prosthesis, it's a PFM, doesn't flex. We shouldn't have a whole lot of problems with this case. However, that was not the case. This is at insertion, and then this is when he came to me after 1 year. Multiple fractures. You can see the incisal edges have been eroded. You can see the metal showing through. On the premolar, for instance, you can see some of the metal, and the prosthesis does not look good. It has multiple chipping. Look at the chipping on the on the premolars and the occlusal wear. So I decided, being naive and ignorant here, I decided to take this patient into zirconia, right? A full monolithic zirconia with layering in the anterior. And as you can see, this prosthesis was very highly scalloped. It did not have the correct connector dimensions, I'm thinking, and it just wasn't strong enough. And the major problem that it had, in my opinion, was the problem that we talked about earlier. And then again, this is the prosthesis on passive abutments. And I put the patient in the PFM. Forget the PFM. So then the patient wore the zirconia prosthesis for about a year. And then he showed up to me and he says, you know, every time I bite down, something is moving. And so when I removed the prosthesis, this is what I found. So the prosthesis snapped in half. The monolithic zirconia broke in half. So I put the patient back into the PFM and we go back into the drawing board. You see, this is the situation that he had, right? First, he had a PFM, then I took him to a monolithic zirconia. But like we talked earlier, zirconia has no elasticity. This guy is a bruxer. Every time he bites down, his jaw flexes. And because the connector spaces was very thin in between the laterals and the centrals, this prosthesis snapped in half. So going back to the drawing board, I decided to add 1 more implant and to give him another monolithic zirconia. But this time I was going to make the monolithic zirconia very strong. So we go back to the CAT cam again. We design an additional implant. I add another implant, put the patient back in a PFM, take a full arch impression, take this back to the lab. And here you can see we are thickening up the connectors. We are thickening up the connectors where there's double conics there. We're thickening up the connectors in the embrasure spaces. And we are making sure that this prosthesis is gonna last beyond the patient's lifetime, right? And people may say, no, this, you know, patients cannot tolerate that. It's very thick and nonsense. That is not true. I have been putting hundreds of these cases in, and never have I had a patient say to me, oh, doctor, this prosthesis feels too thick. I'm not saying PF2s and thin prostheses is not the way to go. I think they are, but with the full monolithic zirconia, there are some aesthetic ramifications. So again, going in there and thickening up that zirconia prosthesis in places where it's needed. Once we do that, we put that in the patient's mouth. This is the full view of the case. And this case has been in function for about 2 years, no problems. I put this patient in a night guard, and he's a family friend. So I talk to him often, and he always tells me that the night guard has stopped his sleep apnea. He's no longer clenching. And obviously the 5th implant there significantly changed the things that were done. And here's the same case on passive abutment. So a night guard is incredibly important on every full mouth monolithic zirconia, because the monolithic zirconia is so stiff and so hard and it doesn't wear. We don't know what's happening to these type of cases as of right now. So it's important to put these cases into a night guard. So when we're designing our monolithic zirconia, this is a case from my friend, Dr. Safa. We should over-engineer and over-design these monolithic zirconias, because bruxism right? This is a case of a patient in PFM. It's real. It's a central nervous system problem. And if you put patients on a PF2 with double cantilevers or tooth-only defect with multiple ponic spaces, you will have problems down in the line. So if you're traveling and your phone rings and a patient has a complication, that's not a good thing for anyone. So for example, a prosthesis like this, where it's a monolithic zirconia, first of all, there's no reason to have a second molar on this tooth. There's absolutely no reason. You're setting yourself up for failure with such thin connections. And then maybe you can thicken up this prosthesis. There's no reason not to do so. And right there is a criteria for failure. It will fracture right there if it hadn't fractured in the distal extension of the second molar. And this is another case, long-term, it was given to me by another friend. You can see the wear of the PFM, how the PFM does not do well with time. Fractured, snapped right down the middle. Patient was taken back into a zirconia prosthesis. But what I want you to see, the spread is okay here, but look at the design on the lingual aspect. Look at all those crevices that food can get underneath. Why would you even scallop that? Why can we have zirconia inside of those embrasures to make this prosthesis stronger and long-term, so that this patient never has to see us again? He's already had one failure. Why a second failure? So this prosthesis should have been designed differently. And then obviously everyone goes into a night guard. So when we look at the x-ray here, maybe the bone reduction was not appropriate from day one. This patient initially was maybe planned for FP1 and then it became an FP2, but maybe it was better to plan for an FP3 from the start and have thicker connections and lack of cantilevers. So with that, I conclude this lecture, and I hope I was able to convey the message. And the message is, you have to have surgical aspirations. You can't start a case and then halfway decide what you want to do. You can't put patients in removable prosthodontics and load them later, because right now we know that immediate loading is working. You have to have a set plan. You have to have a protocol, a surgical protocol, and you have to have a responsibility and a commitment surgically and prosthodontically to the patient. Because if the patient is going to have a hip replacement, for instance, you have one hip replacement in your life, right? You don't have two full arch all-on-4s in your life, or three, or redos. There should be no difference between a hip replacement or a double knee replacement or a knee replacement with a all-on-4. It's essentially the same thing. We are giving back a body part. We're giving back something that is very emotional for the patient. We are changing the people's lives. We are extending the platform of hope for these patients. We are affecting them long-term, lifetime. They don't like to come to our office. They certainly don't like multiple appointments, and they like to be done as soon as possible. So with that, I conclude this lecture, and I hope you enjoyed it.
Thank you, Dr. Safa. Thanks for sharing all your experiences with us there. Definitely taken some tips from that. You know, zirconia, there's a lot more talk about zirconia as the final prosthesis out there. And, you know, we've, and some people still have some doubt, but thank you very much. And I'll raise why I say doubt in a second. It's got to do with passive, but just want to say thank you and really, really appreciate that.
You're welcome. Thank you. Thank you for having me. Thank you for doing this, and at such times where people have the time to read and re-educate themselves. I've certainly been doing it. I've been watching a couple of lectures a day, and so thank you for doing this. You're certainly giving people something to do.
Oh no, thank you. I see Dr. Ackerman is on the webinar as well, so shout out to him, and thanks for all his inventions and input to Southern's as well.
Hi, Andrew. Meet you.
Dr. Safa, I've got a question that's got to do with the passive abutment and the milling of the seat within the chimney of the framework.
Yes.
Do you have any, for instance, if we go back and we look at the coaxial implant with the cross section of a coaxial. So the question we often get is that implant strong enough? We go into the detail of engineering, and we haven't seen any breakages, you know, hardly any breakages of that. With the passive abutment and milling within the framework and milling the seat within the framework, What is your feeling on the gold screw sitting on that zirconia ledge?
So this is a very good question, because I think initially the passive abutment was at implant level. And initially the passive abutment was for metal ceramic restoration. And so I think metal had a little bit more give inside of that chimney. So when we started doing zirconia, then we had to go back to the drawing boards and do a little bit of the mathematics. So I think that chamber needs to be milled properly. It has to have the right dimensions. I think Southern Implants has already sorted that out. Initially, I remember in 2013, when I first did my zirconia passive abutment in a lab down in South Africa, we did have some issues. I think since then, all of those issues have been sorted out. Dr. Fokion Etridis has definitely had some input into this. So I think right now with my laboratory, I use a lab here in the United States called the PNR lab. They have pretty much nailed it down. It goes down to the CAD, to the CAM, not the CAD part, it goes down to the CAM part, the manufacturing part. The ledges have to have certain dimensions, mathematical dimensions. Those dimensions have to be downloaded from the Southern library. And then once that's done, then, you know, whether you should use a titanium screw or a gold screw is a topic, a debate that we can have for many hours. But one thing I would say is that that gold screw, in my opinion, is better inside of zirconia, because again, zirconia is a very different material than metal. And if we can have a screw that has a little bit of elasticity, such as a little bit of give, such as the gold screw, I feel more comfortable. But gold screws are more expensive, right? And so I was talking to Graham, and he says, we have changed our titanium screws a little bit, so which is no longer a problem. So I would prefer the gold screw. I know Dr. Andrew Ackerman goes implant level on his full arches, and he uses a gold washer. I don't use the gold washer because I restore to multi-unit level, so there's no space. So I prefer a gold screw for the multi-unit screw. And then, but then again, the only big disadvantage here is the cost of that gold screw.
No, thank you. You know, well, great answer. You know, we haven't seen much negativity around it, but it's good from a clinical perspective, your input on that point. Thanks.
I think initially there was some problems, but I think those problems are sorted. I think it has to do with the technician. The technician has to be meticulous. Again, it goes down to the CAM part. You may have some issues in the start, but then once you sort them out, it becomes a workhorse. The passive abutment is the only abutment right now, in my opinion, that can give you a 2-micron fit. It's the only abutment that can give you a passive fit when you have multiple implants. I don't think you can have that with any other system. The tie base is what most people use, but as you can see in my lecture, people got out that inside of that, and then they cement it over, so it's no longer screw retained. It's almost as if it's cement retained. So I think the passive abutment is really a great invention, and in my practice, and I used it in my own mom, I used it in my own father's mouth. I mean, I believe that this is really the appropriate abutment.
Yeah, thank you. There is a few comments on the Q&A side of things, but they're all just complimenting you on a fantastic presentation. The one comment here is, just want to thank you for advocating the passive abutment, still the best concept ever, from Mr. Anonymous. And then you got some fans out there, Dr. Safa.
Yeah.
Really. There is one question. What is your go-to occlusion for these cases? From Dr. Michael Swirsky.
Yeah. Michael Swirsky. Mike was my classmate in dental school. He actually sat on my left side. He was my partner about 15 years ago. So hello, Mike. Mike, the occlusion that we use for these type of prostheses is a anterior guidance. So, you know, unfortunately, we don't have a whole lot of data on the appropriate occlusion on a monolithic zirconia. One thing I would say is that with the hybrid prostheses, the problems that we saw is that as the posteriors began to wear, then there was a whole lot of contact in the anterior. And every time the patient went into protrusion or into occlusion, they popped those acrylic teeth off of the hybrid. We don't see that with the monolithic zirconia. So I think any occlusion that gives you an anterior guidance, I think the appropriate occlusion for the monolithic zirconia is group function, if we can establish that. But then again, this occlusion on lateral guidance and no interferences on lateral movements, and eccentric occlusion, and the same occlusion that unfortunately we don't have a whole lot of data. So the same occlusion that we apply for the prosthodontic full arch reconstruction, we apply to the monolithic zirconia. But then again, it's very important to have these cases in a night guard, because I think it definitely increases the longevity.
Dr. Safa, another comment here. It says, can you remember dentistry before, or implantology before the coaxial implant? It was like driving a car without power steering.
That is absolutely true. The coaxial implant is, again, another wonderful tool, because it gives us extra space. It gives us screw retention. It avoids us from using cement retention. It's really an excellent implant. But having said that, though, it's a difficult implant to place. And so it definitely needs you to take a course. It definitely needs for you to attend a couple of lectures. And it definitely needs you to place some. Maybe the first couple may not go as good, but once you understand the concept and once it works in your hands, I think the coaxial implant is wonderful. I personally would not place anything other than a coaxial in the anterior maxilla.
Okay. Yeah. Thank you. Dr. Safa, one other point I just want to, the seating of the straight multi-unit abutments on, a subcrestally placed implant. What is your protocol there?
What do you mean the seating? Can you explain the question?
So because the implant is placed subcrestally or deeper than normal.
Yes.
So when placing your multi-unit abutment, what is your protocol?
So one of the protocols that I would say is that the multi-unit abutment must be placed deeper, right? And we saw why. Right, so you either have to have your lab analog, when you're looking at your model, either the lab analog has to be deep down into the model so that you can have running room, so you can have the right profile, or it has to be right flush with the gums. It can't be higher, right? And I think sometimes it's higher because for two reasons. We don't place the implants deep enough, or what we do is we use taller multi-unit abutments. And one of the reasons why we use taller multi-unit abutments is because it's easier, right? You don't have to do a whole lot of bone milling because the profile starts a little bit higher. So there's no, so what my protocol is to place the implant subcrestal, depending on the amount of tissue you have. We've all seen the papers from Thomas Linkevicius. Once the implant has been placed subcrestally, then the multi-unit needs to go a little bit deeper, but bone may have an interference. So on the external hex, you must bone mill, right? But a couple of years ago, Southern Implants came with a beautiful thing with the external hex, is that they started platform switching the 4 millimeter. We were able to platform switch the 5 and the 6 millimeters, but we were never able to platform the 4. But now the IBNT multi-unit abutment fits on the IBT. So now you can platform switch that. So that has reduced the need for bone milling. And so for non-external hex connection, because I use internal hex now, for internal hex, such as the Provada, then it's a little bit easier. I have experienced it to be than the external hex. Again, there are some handheld bone mills that you can use. And then the last advice I would give is always try to go for the shortest multi-unit you can. You don't want it to be sink down deep in there, but as I showed you in the picture, once you approximate the flap back over to the implant, the head of the multi-unit should be flush with the gums, because that gum is going to have a little bit of dieback. So if it's flush or slightly over, once it has dieback, then it will be at the perfect height. What you don't want to do is you don't want to have a high multi-unit abutment. So my advice to those people who try to restore a multi-unit abutment that's higher than the residual ridge is, unfortunately, I'm sorry, counter torque that multi-unit and put a shorter one in. If you have a 2 or 3, change that to a 1. And so, but the disadvantages of that is that you're breaking that one implant, one abutment, one implant concept, one abutment, one time concept. You're causing bone remodeling and you're causing changes around the crest of the bone. So I don't really recommend that. It's better to get it from the start, place the implants deep enough. And so I always have this conversation with my surgeon. I say, please place those multi-unit abutments as deep as you can.
Yeah, Doc, yeah, I think our Southern's engineers have responded to you as well, and they have redesigned those multi-unit abutments to be a little bit more scalloped.
Yes, that's also true. Absolutely true. For the external heads, they have done that. Absolutely true.
Yeah. And well, yeah, I think with the internal connections as well, but also they've obviously anodized it in a gold color because you're seating it a lot deeper.
Yeah.
So
exactly. And the gold color is very helpful because now if you do have dieback, maybe the profile may be a problem, but definitely aesthetics wouldn't be a problem because it wouldn't show. So yeah, Southern has definitely done their homework there. There's a question here from Liam. Would you load a trans-sinus implant on the day of surgery? And the answer is yes. If you look at the literature on zygomatic implants, a lot of these implants, zygomatic implants, are trans-sinus, and we are loading them. So with the appropriate, again, with the appropriate primary stability, with a rigid prosthesis, with a cumulative primary stability of 120 Newton centimeters of torque, evenly distributed amongst all of the implants, I don't see a reason why we cannot load a trans-sinus implant on the day of the surgery.
Okay. Yeah, no, some further comments here. Great presentation. Thank you from Dr. Jay Chan, Dr. Petros from Dubai. Perfect presentation. So
yeah,
I know it's all good. Dr. Safa, yeah, I'm going to wrap this up. But again, really appreciate your time. Really appreciate you know, sharing your knowledge on these on this hot topics, and really appreciate it. Again, to the audience, thank you for signing into the webinar, and again, appreciate that. We haven't got anything scheduled for next week, Wednesday. We are considering maybe changing the time of our future webinars. We have got more coming up on the horizon, but maybe making it later because as people are getting back into their practices, it allows them to tune in at a later time.
One thing I want to say about Stuart Laton made a comment here, which I forgot to mention in the lecture about stain development. He says monolithic aesthetics will only get better with time, with stain development, and I agree with him. He showed me before Stuart, I always thought that there should be some minimum staining in the anterior, but with the monolithic zirconia that Stuart Laton is doing in Ireland, with his all-on-4 protocol and his beautiful bridges he does, he sent me a couple of cases, and boy, I was taken away by the work that he's doing with his zirconzan bridges. Very little staining, and these prostheses look absolutely beautiful. And we always say this to each other, that these patients will probably die with these zirconia. So to the end of time, these monolithic zirconias are going to bypass not only the patient, but maybe even thousands of years. so very beautiful work he does there, and I can't wait to go down to Ireland to see the wonderful work that he's producing.
Oh, it's a lovely way to end this session, Dr. Safa.
Thank you.
This presentation will be available by the end of the week on our website. You can log on there, catch up on the past presentations if you've missed. But again, please stay safe, stay healthy, stay positive, and yeah, love from all the Southern's team around the world, and hopefully see you soon. Thanks again, Dr. Safa.
Thank you so much. Take care.
Okay. Bye-bye.